Stan Becker is a Professor Emeritus at the Department of Population, Family, and Reproductive Health at Johns Hopkins University School of Public Health. Stan, thank you so much for taking the time today.
Glad to be here.
So to start, can you talk a little bit about your journey, your career journey in public health and the work that you've done?
So I started way back, went to college in the late 60s, early 70s, and it was the time of Vietnam War, and I dropped out because we were closing the University of Chicago, and my dad was paying tuition, a little bit of tuition. Anyway, so I went to Mexico. And the reason I say that, I went to Mexico, and it seemed like there were children everywhere. And I saw some of the American Friends Service Committee was working in family planning down there, and he said, "You're right. In the U.S. at that time, 20 of 100 people, 20 would be below the age of 15. And in Mexico at the time, for 100 people, 50 would be below the age of 15. So because they had high fertility, and he had told me in addition, Mexico City was growing so fast, both from high fertility and from immigration from the rural areas, that just to keep up with the population growth, they would have to build a school a day. And they weren't doing that, obviously, and they still have apparently 3 shifts. The primary goes in the morning, the secondary in the afternoon, and the high school in the evening to use the same buildings. Anyway, so I came back the next year to the university and went to a professor in population and said, "I'd like to help on this. What can I do?" And he said, "We have plenty of bleeding hearts. If you really want to help, take this calculus course and this linear algebra course, and then come back and I'll talk to you." And I did that, and he said, "Now take this advanced algebra course and take this computer course and take this other course and then come back and talk to me." I did that. And then he said, "Take this population course," and whatever. Came back, and he put me in a master's program because I'd finished my bachelor's by then, and I came out the other end a demographer. And so that's how I got into it. And I felt it belongs in public health all along. So I was glad to be recruited back to Hopkins after my doctorate. I lived overseas for 7 or 8 years in between. Anyway.
Yeah, that's awesome. And so can you talk a little bit about what the field of couples and reproductive health is and why it's important?
Yeah, that was my thing. I went, how was it? The 1994 Cairo Population Conference. The UN had these every 10 years, starting in 64, I think it was. 94, it was in Cairo. And I went, and the theme was really women's rights, or one of the sub-themes was women's rights and men's responsibilities. And they had whole sessions where they were talking about this. And I thought that's not quite right because men have some rights and women have some responsibilities. So anyway, in the sexist and patriarchal world we live in, that made sense. But on the ideal is that you'd have both. Both would have both. So I came back and took a mini sabbatical at the university and wrote a paper called Couples and Reproductive Health, which was published in 1996. And really, I was at the forefront. The work had been done earlier, but people hadn't put it together. So it was a literature review, really, of all the studies that showed that involving husbands does make a difference. So I started a course and kept publishing papers till I retired with students on things like secretive use of contraception, that sort of thing. But one has to list the reproductive health components, which are much more than just family planning. We have infertility, we have sexual behavior, we have breastfeeding, we have contraception and sterilization. And so there's a whole gamut of reproductive health components. And it's been shown in almost all of those that involving the husband, and I say husband in this country would be partners because a lot of women aren't married, people are in cohabiting unions. Anyway, in most of the world, to be husbands does make a difference, including maternal mortality. Though the studies are there a little weaker, but if she's suffering from something, he's going to be the one that can mobilize resources to get her to a hospital, for example. And the problem, one of the problems has been, it's been the medical profession, which has done contraception, for example, and they treat one person at a time. And that it's so stupid because they only realized there was a paper just a few months ago on bacterial vaginosis. And lo and behold, the physicians did a study and they found that if they treated the partner, this was up in New England somewhere, she had less repeat bacterial vaginosis. Now, it used to be thought that bacterial vaginosis was a women's thing. The men didn't anyway. So now they know he can spread it, whatever. And you know how the same thing happened with HIV. They were testing for women for HIV in Africa when they came for antenatal clinics. And if they got wrong, first of all, the prevalence, they took prevalence from that, prevalence of HIV, and it was too high because some women don't have sex and don't come to antenatal clinics. But the more important thing from the couple's perspective is they just treated the women. And if you treat the woman, the man is the one who gives it to her. So you better treat him, get him in. So we did one study in Tanzania trying to get the husbands in for testing at the same time. Because if he's positive, then you're going to do things differently than if just she is positive. Anyway, so the problem is the field is very much, since 1994, it's a women's rights thing. And people haven't really focused on the male, lots of women's empowerment and this sort of thing. But you have to realize, even with women's empowerment, you have to include that she's in a setting. We had a study in Bangladesh, and we asked questions about domestic violence. And if she had been hit recently, we referred her, or beaten recently, referred her to a counselor in a neighboring village where they were. But what's the counselor going to do? At that time, there was only one place for battered women was in the capital city, 100 miles away or something. And so she basically had to go back to her household that night, cook and take care of the kids and that sort of thing. So except in involving the village chief or something, there wasn't much that could be done. So you have to, talk to the men and get them to stop beating their wives, that sort of thing, which is not easy, but you have to take a couple perspective at some point.
Yeah.
And
Wow.
sterilization is the same thing. All over the world, except for 5 or 6 countries, I think, there's more female sterilization than male sterilization. Well, when you're in a couple and you decide not to have any more kids, choose sterilization, but gee whiz, the vasectomy is cheaper, is outpatient, has less side effects and all that sort of thing. So if we're in a gender equitable world sort of thing, there should be more vasectomies. And the problem is people focused on the women too much. Not too much, but at the exclusion of men. And folks are finally realizing that. Said more
Yeah.
than I need to hear, probably.
Well, no, that's great. And I'm curious, you kind of described this a little bit as you were talking, but can you talk a little bit more about how our thinking has changed on global reproductive health over the past 20 to 30 years?
Yeah, well, before 1994, the focus was on family planning. And people didn't say reproductive health much at all, except for a few academics, maybe. Anyways, family planning is not really correct either. It's contraception, because family planning includes abortion and even infanticide, people planning their families. Anyway, so it's contraception. And at the 1994, as I said, women's perspective took over in some sense. I mean, that's not quite the right word. Anyway, was front and center. And the demographers, there were a few of us there, were kind of put to the side. Before that, governments had targets. India is a good example. They had contraceptive targets. Each health worker had to get so many sterilizations or so many IUD acceptances in a month. And that led to abuse. And that was highlighted. And, so after 1994, countries abolished targets. Basically, it snuck back someplace. Apparently, Amy can tell you about that. But so the perspective changed from a government perspective. We need to limit fertility because of rapid fertility is a problem, to the individual perspective of human rights, sort of thing. And a little bit goes overboard because the individual rights are okay, but we also have to recognize that we're in a given country. When resources are lacking, then the government has an incentive to decrease fertility. It's not just the individual women, so they have to And what they can do, of course, in this the reproductive rights setting is do propaganda, if you will, or these telenovelas that show how much better a couple is if they only have one or two children rather than seven children, sort of thing, which governments have done. In Bangladesh, for example, had these. They had something called Shuki Poribar Chuki Choto Poribar Shuki Poribar, which is small family, happy family, and they had uh, actually, what do you call it? On the highways, you see the big posters. Anyway,
Oh, the billboards. Yeah.
boards. Yeah, they had had them, and they had on one side a family with two children, and they had shoes on and school books and looked great, nice clothes. And the next family had five children, and they didn't have shoes, and their clothes were in tatters and that sort of thing. And they had this motto there, and sure enough, it convinces people, and they realize in Bangladesh, if you have five kids, you can't divide the land you've got into five and have a sustainable, the kids won't be able to make a living on it. So indeed, fertility in Bangladesh came way down. So the governments do have an interest, and now we're seeing the other way, where fertility is very low. Governments have an interest in trying to increase it.
Yeah. Well, so what trends are you seeing now globally with regard to both demographics and reproductive health?
Yeah, so demographics, obviously, anybody that reads the media sees that fertility is coming down, and over half of the population of the world are in countries that live in with fertility below 2 per 2.1 per woman on average. The problem is people don't understand that. That doesn't mean population's declining. Maybe 50 years from now will decline, but there's something called population momentum, and you need a little training to understand it. But you don't really need training, because if you think about, if you drive a car and you slam on the brakes, you don't stop right away, right? So it's momentum, population momentum. So because the age pyramid, if you think about age going up this way and the numbers across, then when fertility is high, you have a very wide base. And now in a place like the US, you have something like this, or in Europe, it's even like this. There's more people on the top than the bottom. And because where you have a very wide base, even if those people only have two children, population continues to increase for about 60, 70 years. And a good example of this is China. And China had fertility below two from about 1994, somewhere around there, below two children per woman. And it wasn't until 4 or 5 years ago that they actually had more deaths than births. So the number of countries that have more deaths than births, last I looked, was 15 or 20, even though there's probably 60 or 80, I can't remember how many, about half of the countries in the world, no, half of the population. So it'd be maybe 60 countries have less than 2.1 fertility rate. So that's a major change. And with that comes population aging. So Japan is very low fertility, and Korea, and they have rapidly aging populations. And of course, the economists worry about this. Will you have enough hands to help the older people? And I answer that. First of all, the population of the world is increasing still every year by close to 70 million people. So it's a distribution thing. Most of them are in Africa. But also in Japan, they figured out, when I graduated from high school, about half of my classmates went to work at Oldsmobile. And maybe it took 100 people to make a car with a different piece on the assembly line. And now maybe it takes 5 people, and one of them is watching the computer. And Japan is even more mechanized, and they have the robots doing it. And the same thing, they've got robots that'll keep you company. And for older people, they've got robots that can turn you over in bed. So it's not necessarily true that we need more hands. We need a lot of younger people to take care of older people. And they're seeing. I was reading the other day in the paper. They've changing schools into daycare sort of thing for older people, because some towns, the schools had to close. There weren't enough kids to keep the school going. So, anyway, that's a major concern, is aging, and it's overblown because by definition, when fertility comes down, the population ages. So it's getting used to that is what governments have to figure out. And like I said, Japan's, they're not doing too bad. I guess their economy is not as strong as it might be, but they're not poor.
So what policies and programs should we be advocating for as a society globally right now?
Well, the main thing is access to contraception. And of course, sex education comes in there. A lot of places don't have good sex education, including this country. Um, there's a joke there. You want to hear a joke? This
Sure.
this father takes his 15-year-old son aside and says, "I think we need to talk about sex." And the son says, "Okay, Dad, what would you like to know?" So they're getting better sex education than our generation and in between generations. But still, it's anyway. Sex education is not very good in some places. When I went through school, they showed a film of STDs, and if you do it, you'll get this sort of thing, and that was about it. Anyway, so sex education, then availability of contraception to anybody who's sexually active. A lot of places have these what do you call it? Sanction have they look down on people who come who aren't married. Um, there's a word for that. Anyway, so in places where marriage is where fertility happens, and if a woman is unmarried and looks for contraception, she may have trouble getting it. When I lived in Bangladesh, somebody who was unmarried apparently left a baby on the steps of a church, and
Hmm.
because the stigma involved in her having an unmarried woman having a baby. Anyway, that's not true in this country, at least, in other countries, but still, contraception and the unmet need for contraception or unintended pregnancies are still 40% or so in this country. That means people are getting pregnant that don't want to get pregnant, either at all or a timing problem. And of course, then you get to abortion, and abortion facility, safe abortion should be accessible. And, if people choose not to have abortion, that's fine for religious reasons or whatever. But women who don't have access, they're going to get abortions anyway. And you get back alley abortions, and uh, women die in childbirth and having abortions. And this, I worked at Center for Disease Control, um, and my boss was head of. We collected abortion statistics and maternal mortality statistics, and he said before Roe v. Wade, when abortion was illegal, he said there were more abortions in Grady Hospital, more deaths due to abortion. Grady Hospital was the major public hospital in Atlanta, and women would come from all rural areas there. There were more women dying from botched abortions in Grady Hospital in 1 year than in the whole country after legalization. So, and we're talking 4 or 5 deaths after legalization, and we're talking 10 scores of deaths before legalization. So, um, even if you oppose abortion, women are they're gonna have them anyway. So make it accessible, and that's true all over the world. Um, and countries have, except for this country, there's been a trend to liberalize abortion laws. So it's illegal. It's legal in Mexico now and several places in Latin America. Not sure which countries, maybe Brazil. You'd have to check, but yeah.
Yeah, so what do you think the future of this work is, and perhaps specifically the future of the research related to this work?
Well, it's a big question and a little question within the big question. The big question, I've been working on this, is population. Training in population has declined, partly because of this switch from 1994 conference. People aren't interested in population per se anymore, and that's a shame because we need people to work at the Census Bureau. We need people to keep track of immigration, to keep track of, to analyze mortality and those sorts of things. And even in public health, people say population health, and that's not correct, because population health is really just focused on mortality and morbidity. Migration is not population health, nor is marriage and divorce not really population health. It has aspects of it, of course. But anyway, so to train a demographer to do projections and that sort of thing is problematic in this country now. There are only a few schools that have advanced training in demography. Now that's the bigger picture. If we come down to reproductive health, you were asking about policies going forward in the future.
Yeah,
Well,
and
that
and research as well. Yeah.
Yeah, research. I'm encouraging people still on the couples and reproductive health. There was a paper recently that we need new measures in family planning. That we've stuck with this unmet need, which is a problematic measure, and demand satisfied. Anyway, there's technical things that we should fix when we do surveys. Of course, there's a big problem now in this country that administration has cut funding for all these things. So the surveys that we used to do around the world, and I was involved in evaluating some of those for the demographic and health surveys. Anyway, that money's been cut close to zero, and so we don't even know the status. Won't know the status of population things, contraception, fertility, and all sorts of things in many countries, unless they have enough money to do it themselves, which is a few countries do, but most places in Africa don't.
Yeah. Well, Stan, thank you so much for taking the time to talk to me and to share insights. And I hope we can continue the conversation down the road.
Sounds good. Thank you.